Calcutta and is a very prolific orbital surgeon. So over to you, Shahid.
Good. Can you connect this? Yeah, it's connected now. So good morning everyone. So without wasting much time, like both of my colleagues have their separate other presentations. So I'll be talking upon orbital fractures, what implant suits your patient the best. So just to give a brief background, we have come a long way. The orbital fractures were first described by Mackenzie in 1844, and then in 1957, Smith and Reagan, they described the blowout fracture, and then various authors described different implants for correction of orbital fracture repair. So when we choose an implant, the key factors are the timing of surgery, the surgical competence of the surgeon, and then choice of implant is what I'll be talking upon. So in our life, when we look for our match, so these are the things that generally we look upon, that our life partner should be compatible, she should be or he should be non-irritating, flexible, supportive, available for you in difficult times. Some people also think of figure and contour, and then the wallet size also matters. So when we transpose these factors to the orbital implant, we see that similar to our choice of an ideal partner, these implants should also be biocompatible, they should be non-allergic, flexible, they should support the ocular structures, and yeah, of course, they should be available in sufficient quantity. They should be easy to contour along the orbital walls, and yeah, and they should be cost effective in the Indian scenario. So what are the other available options? We have a lot of options for orbital implants, ranging from autologous, allogenic, xenograft to alloplastic, different alloplastic and polymers. And right now we have also a composition of different implants together, which is known as composite implants. So what are the factors which influence our choice when we decide upon going to repair a fracture and think upon what implant we should use in the particular case? So of course the important thing is the defect size. What is the size of the defect? What is the amount of inophthalmos? Is there are there multiple walls involved? Adaptation to internal contour. Do we need to restore the volume, or just that diplopia or EOM we want to correct? And whether it's an early fracture or whether it's a fracture which has been there for quite a long time. So just to briefly describe few cases, this is a patient who presented post-trauma. As you can see here in this picture, there's a limitation of movement in the upward gaze, and this is her CT scan, coronal, axial and sagittal view, and you can see it's a typical teardrop sign where the blowout fracture has given way and then snapped back to its position, entrapping the inferior rectus muscle in the process, and that's what is causing the elevation limitation. So in this particular case, what you don't need a volume restoration, just need to release this entrapped muscle and put something there so that it doesn't go back. So that's what we did. We released the muscles, and here we have put an osteomesh implant, which is an absorbable implant. And this is the post-op result. You can see that elevation has quite nicely almost come back to normal. This is the second case. So it's a 13-year-old boy who complains of diplopia post-accidental fall. And as you can see in this picture here, there is a limitation of adduction in this eye here. And this is the CT scan picture. Typical, the most common location for orbital fracture, the infromedial wall, which has fractured, and some of the orbital contents have herniated there. So here in this particular case also, you don't need much of a volume. So here also you can see post repair, the adduction has very nicely corrected here. EM almost has become full here in this picture. And we generally do post repair imaging for all our cases to see what is the position of the implant. Has it gone inside nicely, whether it's resting on some important orbital structures or not. And we put a titanium implant, as you can see it's very nicely placed, and in the sagittal section and both in the coronal view also. This is a 3D image. And so now this is a case where you typically need to restore volume here. See, large blowout fracture, almost all of the content is in the orbit. And this is the post fracture repair. Inophthalmos has been nicely corrected. And another case, both of them where you need to restore volume. Here also see, there is a large fracture of the floor. There is a lot of inophthalmos here. So in these cases where you need to restore volume and the fractures are quite large, so these cases you can put a composite implant, which we generally use bone or like a titanium plate implant over a bone. So here an onlay has been given. This is the iliac crest, bone harvested from the iliac crest, and over there we have put a titanium implant to restore the volume. And as you can see here, the volume has nicely been restored. So where you need to typically put large amounts of volume, you can put a composite implants like this. Now this is another case, a challenging case which we recently encountered. This police inspector from Bangladesh injured in a bomb blast. So this is an artificial eye. A scleral shell has been placed here, and lot of psychiatrical changes in the lower lid also. But what is important is this 3D recon image of the patient. You can see this is a typical quadrangular quadripod fracture, as we call it here, where the lateral wall has been disrupted at the ZMC, at the zygomatico-sphenoid suture. The maxilla has got detached from the zygoma, and there is a floor fracture also. So tripod plus a floor fracture, a quadripod. So in this case you have to do a typical 3-point fixation. That's what we have did here. So you can see here the lateral wall has been replaced by small mini plates and screws, and then we have just tried to contour the floor here. The rim was missing. It was an impure fracture, so we have to try to put recontour the rim by putting a mini plate here also, and then we have joined the maxilla with the zygoma by the intraoral route. And this is the post-op image. See that the inophthalmos and all has nicely been corrected, and this is the post repair imaging. All the plates and screws in place. Now this patient he needs a repair of the soft tissue, the cicatricial part. So another case here. So just again a blowout fracture of the medial wall. The whole medial rectus has gone into the ethmoid sinus. So in this case also you don't need much of a volume. You just need to go and bring this medial rectus in its original position. So what we used in this case are X-ray film. So X-ray film also can be used. You can sterilize them and contour them, and because in cases where you don't need much of a volume, you can even use a X-ray film. So this is the last case here. So this is a post-op image actually. So you don't see much of inophthalmos here. There was not no movement limitation. Diplopia had nicely corrected, but then patient was not convinced that there was no scar mark. How did such a large implant go inside? So we would only do this thing, post-op imaging. So for this particular case also we did a post-op imaging, and we showed him the implant. So just to emphasize upon that, most of our MaxFax colleague, they take the incision as they take a subciliary incision, which actually results in a cicatricial ectropion. But that's the advantage of a subconjunctival incision, that it's also cosmetic and it doesn't give you that tethering effect that's there in the subciliary incision. So just to conclude, a surgeon's view or the surgeon's view of an implant. So it should cover the entire defect. It should conform nicely to the walls, and it should match the volume of the uninjured orbit. And it should not migrate, that it should nicely support. It should not cause hypertrophy, that you are not placing the implant over some extraocular structures. And it should not necessitate removal or debulking that like commonly happens in large bone grafts, like some of the MaxFax they generally put it. So this is just a review of different implants, like all the factors they have taken into account, and they have compared like what implant gives you the best of what factors. So as I said, that the perfect match, the choice of a perfect match, like we keep looking upon, and it's not like we can decide upon a single case that okay, I'm going to put such and such implant for all my cases. You have to customize your implant depending upon the size of fracture, the functional defect, and the need of the patient. Okay, thank you. So next I like to call upon Dr. Akshay, who will be speaking upon NSOIDs. Right, Akshay?
Yes.
Yeah. So Akshay is a prolific oculoplasty surgeon and attached to Aditya Jyot and lots of freelancing. Right, Akshay? Yeah.
Can we connect it now? presentation. Cut रहा हूँ. Perfect. So I am talking about orbital inflammatory disease, also known as non-specific or idiopathic orbital inflammation, or NSOI or NSOID, or orbital inflammatory disease. The first question is, what is this? So it's not a condition, it is an open-ended non-diagnosis where we actually do not know the cause for the inflammation. It is, and as we know, inflammation is never a diagnosis. Inflammation is the tissue response, and treatment of this inflammation cannot help us make a diagnosis. So in many cases, the response to steroids is not a diagnostic criteria for us to say that yes, this was NSOID because it responded to steroids. There can be many conditions that present as orbital inflammation, and many of which have systemic causes that lead to the inflammatory changes, and therefore we must hunt and look for a cause before we label it as non-specific orbital inflammatory disease. So what all does it include? As we know, in the orbit, each of the structures that are there, which is the lacrimal gland, the extraocular muscles, the orbital nerve sheath, the fat, the apical tissues, and also the periscleral tissue, which is essentially a subset of the optic nerve, the optic neuritis that we see. Remember, none of these structures are, or inflammation of any of these structures are mutually exclusive. You can always have spillover inflammation from one structure to the other. So, clinical presentation, we grossly divided into three silos. So, one is dacryoadenitis, which is involving the lacrimal gland, myositis, which involves the extraocular muscles, and then very often, as we said, spillover is seen, includes every structure of the orbit, which is diffuse orbital inflammation. So when it is dacryoadenitis, this is typically unilateral or bilateral. In many cases it can present with pain, as well as in some cases it can be painless. It is acute to subacute. You never see a extremely chronic inflammation that lasts months. And typically you see an S-shaped lesion, and also on palpation, and many times you will be able to palpate and feel a lacrimal gland. So a lacrimal gland enlargement which is palpable in the presence of inflammation helps you differentiate between whether it's a tumor or whether it's an inflammatory change. The next is myositis. As you can see, this is a far more angry looking eye than the previous patient. This is typically unilateral and is associated with pain, and not just pain along with movement. And as pain with movement and inflammatory changes causes restriction of movement, the patients often have diplopia. Congestion and chemosis are common along with myositis. And as you can see in this patient, she is presenting with severe chemosis, and the extraocular muscles are enlarged. And on imaging, you can see diffuse inflammatory changes all around. Remember, the horizontal recti are more commonly involved than the vertical recti, and bone is almost always normal. There are no bony changes. At the same time, given that it is acute to subacute, thyroid orbital disease and metastasis need to be in your differential diagnosis before you confirm a diagnosis of sorts. And third, of course, is a diffuse orbital inflammation that involves almost every structure, the lacrimal gland, the extraocular muscles. These are very, very difficult to treat because they are unilateral and they keep repeating and often have suboptimal response to medication and treatment. Proptosis, ophthalmoplegia, and of course vision reduction is also there, given that the optic nerve is involved. Again, your differential should include thyroid eye disease, cellulitis, and CCF. So what investigations would you end up doing? The first thing is to image. Now, if you were to image, we have two options, which is CT and MRI. Now, say for example, this is a patient who came with orbital inflammation. You can see and clearly identify the recti and the lacrimal gland, the lateral rectus and the lacrimal gland being involved and inflamed. Now, if you see in this T1 image, you can see that the superior oblique and the superior rectus are involved. But on inversion recovery sequences, you can see that the oblique is no longer visible because that is indicative of an old inflammatory change. Current episode of inflammation is in the superior rectus, which then also on the sagittal slice is visible more clearly. This is how a diffuse inflammatory change would look in the intraconal space. You get hazy shadows, and the same patient on an axial slice, you can see the perineuritis is also present. The same patient here, you can see how the contrast enhancement lights up the optic nerve sheath. In this patient, we also ended up getting a T sign positive on ultrasound. Now, this is diffuse orbital inflammation, where definitely a biopsy would be warranted, because this is the kind of case which you would suspect it to be also sitting on the fence of the lymphoma spectrum. Again, this was a change. Now, you can see here that there are some bony changes also. This is a long-standing sclerotic variant of a non-specific orbital inflammatory disease. Now, in some cases, there is also an overlap with scleritis, and as you would expect, the treatment remains essentially the same, because a CT scan didn't pick it up, but on an MRI, you could see that there was a bullous retinal detachment along with choroidal inflammation. So, when to investigate and what do you do? The specific it's typically not advisable to do the entire battery of all autoimmune diseases at the first visit. So, if there is a mild disease, the first treatment trial would be to give non-steroidal anti-inflammatory drugs and to see for a response. If there is a classical disease where you expect pain on movement, diplopia, proptosis, then you definitely need to do your lab investigations and start the patient on oral corticosteroids with a controlled taper. If there is atypical disease where the pain does not fit in with the symptoms and signs that you see, and the onset is extremely acute, in addition to your basic workup, and of course an atypical disease is also when your normal response to steroids is suboptimal. At this point, you would consider a biopsy, or you would a definitive biopsy, or a steroid sparing agent in consultation with your physician. So, like we said, a trial of steroids is usually given, but remember, a response to that is not confirmatory, because if the patient comes back to you with steroids, at that point you must think of whether you need to do a biopsy or not. And also, like I said, typical versus atypical, I will come back to that later. So, the classic presentation we should keep in mind, which is periorbital pain with edema, erythema, proptosis, chemosis, and possibly vision loss. So, if this is what you typically see, you must consider this to be the classical presentation of orbital inflammatory disease. And in this case, like we said, the first trial of treatment after imaging is systemic corticosteroids. If you get a good response, then you gradually taper it. If the response is good but the patient is unable to tolerate it, then you must consider even intraorbital. We often give Kenacort or triamcinolone injections or into the orbit, such that the patient has some relief from the local depot steroid there, which doesn't cause the systemic side effects. Also, if some symptoms are poorly tolerated, we can start immunosuppressants in these patients, which are non-steroidal or steroid sparing. However, if poor response is seen, at that point you must consider a biopsy to get a specific diagnosis, whether it is vaginous related, whether you have any other vasculitic cause that is causing the disease. And finally, also you need to rule out tumors, because tumors will give a poor response to steroids. Now, when you get atypical steroids, and at that time you have to do a biopsy. So this is basically the third line that we saw there. And here, if you are still able to get a diagnosis of NSOID, then along with your rheumatologist, you must start the treatment. Now, here I want to talk a little bit about this patient whom we had seen for a long time. Now she kept presenting with the classical symptoms. You can see there's proptosis, chemosis, a mid-dilated pupil because there was a loss of vision, and you can see the bony changes was from a prior biopsy that she had undergone. And again, extraocular muscles which are extremely enlarged. We treated her with steroids. She didn't respond well. We did a biopsy, and the diagnosis was sclerosing NSOID, which means that there was intense sclerosis and a lot of hyaline changes. The proptosis remained. She kept coming back with episodes of inflammation. We would start the steroids. She would then respond, and the inflammation would settle down. So that is the before and the after. And at one point, she was unable to tolerate the effects of steroids, so we had to shift her on azathioprine. Again, she came up with severe loss of vision and extreme proptosis. We started again on additional concurrent steroids along with azathioprine. She responded very well. And finally, on maintenance of azathioprine, she was doing well. This was an MRI, and you can see the images, the extraocular muscles have settled down a lot. At that point now, of course, she got married and wanted to conceive and have a child, and they had to stop the azathioprine. So we stopped it, but again she landed up with further inflammation. And at that point we decided to go ahead with orbital radiation, low dose orbital radiation. 2200 centigrade was given, and at 6 months following radiation, this is her post radiation photo. There is absolutely no residual disease. The vision loss is slightly there because of the optic atrophy, but the proptosis, as you can see, has completely resolved, and she also had a baby girl after that. So radiation is also a treatment option, especially in refractory cases. So trial of steroids is given, but when you treat with steroids, do not under-treat. You have to give 1 mg per kg dosage. And biopsy when you have to, because remember, another lesion that also responds to steroids but keeps coming back, but in the absence of pain and inflammation, is lymphoma. And also adequately investigate when you have to. All autoimmune diseases should be investigated. IgG4 is one more thing. Always, it may be advisable if you have done a biopsy to also get an IgG4 immunohistochemistry. IgG4 diseases are a spectrum of diseases which are multisystemic in involvement, involves multiple systems, and also these patients have an increased risk of developing systemic lymphoma later on in life. Sclerosing variant was the patient that we spoke about, and in recalcitrant cases, radiation is an option. So this was one of the papers where we had actually gone back to all orbital biopsies done in the past 10 years and restained them with IgG4 to see what was the outcome. And we saw that 18 cases or 17% of the patients who were previously diagnosed as something else actually had IgG4 disease. So it tells you that almost maybe 1/5 of patients with other orbital pathologies were actually misdiagnosed when they actually had IgG4 related orbital disease. And it's important because systemically we need to tell them about the risk of lymphoma which is there. So I think with that we've covered fairly in detail orbital inflammatory disease. Do we have our next speaker, or Tarjani is supposed to come? So while she comes, if there are any questions, maybe we could answer. Shahid, in one of those photos, I saw that there was a patient in whom we used the X-ray film, I think. There was a suture on the nose. Yeah, so why was that? There was a wound, or? Oh, okay. Okay, I thought that was the root of. Yeah, I just called her up. So the X-ray film actually was published. Yeah, I think, if I'm not wrong, it came in an obscure Pakistani journal from the armed forces. So in the army on the field, probably they had a patient with a fracture and they didn't know what to do. They had an X-ray film, they just sterilized it, put it gave good results. But they published it, and then of course there have been reports even from the West where they have done the same. I don't know if they have explored the possibility, but if it is, there are the films, especially MRI films, when they print, they are nowadays, of course, with the digital prints, it's not an issue. But they're often treated with bromide and silver salts. So I don't know the toxicological aspect of, there could be something that comes up from there. So I think we are in any case in our course we are having 2 speakers who are missing, right? Yeah. Saurabh Kamal is not there.
How good is the response to intraorbital steroids?
Not good, because you get a very short duration of it. It's just this patient, for someone who's unable to, or who's on, say, a cyclical IVMP, and is unable to tolerate side effects of where you in between intravenous steroids, when they need oral supplementation and unable to tolerate that, just to tide over, say, 2 weeks or so, you can give a deep orbital injection. It just keeps them just about okay till they can get their next round of IV steroids.
And then there are some cases actually where you have completed the course of the steroid and disease has almost kind of settled, everything is settled. You can see on imaging that there is not much of inflammation, but patient keeps
Of pain, yeah.
So in those cases also
it helps, yeah. So now I have actually started sending. There's something known as an anesthetist colleague of mine has started a pain clinic, and they actually have a lot of there's rehabilitation counseling, pain channeling exercises, and medication as well. And a lot of these things actually help in reducing and controlling the pain. So I'm surprised that, we should think of these alternate treatment therapies also, and even gabapentin, which can help in chronic pain relief.
Is the sclerosing variety the worst to respond?
To steroids, yes, they really respond poorly to steroids.
Case study, why not choose radio as the first?
So that was a patient that we, as you can see, since she's got married and had a child as well. So that was one of our earliest cases in 2013 or 14 that we treated.
But the problem is like many of the radiation oncologists, they will be reluctant to give.
True, absolutely. Because no, not just that. Those things are okay with them. So you can, if you have a hammer in your hand, everything you see is a nail. So for them, they are looking for that nail. When a nail is a histopathological report that tells it's a tumor. Unless they see a tumor, they will not hit you. So even with thyroid eye disease, there are a lot of studies that are showing that concurrent steroids with radiation or even radiation alone may give better results in active thyroid eye disease as compared to steroids alone.
And the long term also.
And yeah, and
Relapses are less.
but if you refer a patient with thyroid eye disease to a radiation oncologist, you're like,
Unless you know a guy and you have good relations and you are able to convince them, they won't give.
so this patient could not afford the radiation at a private hospital, so she went to Tata, and she was flatly refused at Tata Cancer Hospital. That who is the doctor who's advised radiation? You don't have cancer and all of that. Luckily, she still had the faith, and she pooled her resources and got it done at a private hospital. And
How common is the sclerosing time?
fairly, I'd say about between 10 to 15% of orbital inflammation, maybe up to 1 in 5, between 10 to 20% of cases you end up getting orbital.
They are very difficult.
Yeah. And in fact, during the biopsy itself, the way your blade cuts that, you know it's sclerosing.
You
Because,
cannot debulk it also.
yeah.
You cannot debulk it. It doesn't cut also.
It's like cutting through, if you take in school, you used to have chalk. So you dip it in water and the chalk soaks up some water and becomes a little soft. And then if you try to cut it, it's still grating. And that's exactly like the kind of calcific grating that you get when you cut that, and then you're like, this is... And there is no, because it's sclerosed, there is no space to even inject local steroids. It's a solid mass. It's very difficult, like Shahid said.
And then, in the back of your mind, it's always
Hmm.
So that we are going and removing the mass and coming back.
No, I think she's not picking up. We have the option. I mean, do you want to present something else? Okay, let me just see. Orbital surgery. I think if while we are on, because the course is orbital disease, I could show orbital lymphangioma if we could present that. That's a. ये प्रेजेंटेशन हम डाल सकते, अच्छा डिस्कनेक्ट, ठीक है ठीक है ठीक है, अब देखो So periocular and orbital lymphangiomas can be a very difficult condition to treat. So typically this is how we see what the lesions that we now call as lymphangiomas, which are seen in children, younger patients who've recovered from, say, an episode of cold, or during an episode of URTI, they develop sudden onset proptosis. Now this is a very discrete, well-defined anterior located lesion which we would call a macrocystic type of variant of a lymphangioma. And these are very, very amenable to a transcutaneous therapy because they are directly right there. But they can also be the diffuse variant where you see diffuse orbital involvement, intraconal with extraconal, which is basically transconal, and with lid involvement as well. And in these cases we use bleomycin, where we are able to aspirate and sclerose it. It's mixed with lidocaine and xylocaine and sterile water in a 1:1 concentration and is injected. These are just rough guidelines where we inject about 20% of the aspirate that is obtained. Now this is the same child, because it's an anteriorly located lesion. We are doing a percutaneous treatment where we go in directly. Here we are using a butterfly cannula and we are aspirating it. You can gently move the tip around to all corners of the large cyst to make sure that everything is aspirated. And once that is done, then you inject the bleomycin back in it, and then you can patch the eye. This can also be done with ultrasound. This is courtesy Dr. Bipasha Mukherjee. where you can see under ultrasound guidance, you localize to make sure that the tip of the needle is within the cystic cavity, aspirate it, and then inject the bleomycin, keeping the needle still within the cavity center, and confirm that the location of the tip of the needle is in the large macrocystic lymphangioma through ultrasound. You can see very good results that we obtain through this. This is again one session of sclerotherapy. So to summarize, bleomycin sclerotherapy should be the first line of treatment for all venolymphatic malformations like lymphangiomas. Thank you. And I will now introduce Dr. Tarjani, who's a well-known oculoplastic and orbital surgeon internationally, and she is currently at LV Prasad, where in addition to being a consultant in the Department of Ophthalmic Plastics, she is the Associate Director of the Hyderabad campus. And orbital and socket surgeries has been one of her passions, which she has been involved with for over a decade now. And she'll be talking to us on multiple things.
Thank you, Akshay and Shahid, for holding the fort while I was away. So, good morning, everyone, and again, welcome to our course. So, I'm going to speak to you on customized orbital decompression for thyroid eye disease. I have no financial disclosures to make. You'll see certain full-face photographs of my patients for which we have the consent in place. Now, the points along which I'm going to talk to you are listed on your right side. These are the 10 points along which I'm going to cover this talk. I'm essentially going to take you through why we do what we do in orbital decompression. So there are several types of orbital decompressions. You would have heard about this: 1 wall, 2 wall, 3 wall, 4 wall. So these are essentially the bony orbital walls where, it's the medial, lateral, and the floor. These are the 3 walls. And the 4th wall actually is the intraconal fat, which can be removed to reduce the proptosis. So you're essentially, imagine an ice cream cone which is narrow, and then you have that dollop of ice cream on the top. If you were to make the cone wider, obviously the dollop of ice cream is going to sink inside. So that's essentially what we do in orbital decompression. And whether you choose 1, 2, 3, or 4 walls would depend obviously upon the severity of the proptosis. The more the eye is proptosed, the more you need to decompress to let that eye sit back into the orbit. So these are the 4 walls, and as a paradigm, what we usually do is when you have very minimal proptosis, you can get away by just removing the intraconal fat surgically so that the eye goes back in position. If you have more than that, you add on the lateral wall, even more add on the medial wall, and then last address the floor. Now, why do I say this? So if I have to expand the cone of the orbit, then I am better off doing it in a balanced way. What is balanced? If I remove just the lateral wall, the eyeball will sink laterally. Its center will sort of, move laterally, because now there's more space available laterally. So obviously both eyes will not have binocularity, or they'll not have alignment, and the patient is more likely to develop squint to the tune of almost 30% if your decompression is unbalanced, which means you've removed just the lateral wall. But suppose along with lateral wall, you remove a little bit of medial wall also. So what you've done is you've expanded the orbit, and the eye still remains in the center. It does not move either medial or lateral, and hence binocularity is better maintained, and patients sort of do not tend to have more diplopia post your surgery. So it would be awful if a patient who's come for a cosmetic indication is left back with debilitating diplopia, isn't it? So they wouldn't want that, and hence you have to put all these considerations into place before you consider what you're going to do for patients with thyroid eye disease. So there are traditionally 4 indications for orbital decompression in thyroid eye disease. One is extreme proptosis, like this, which is cosmetically disfiguring. Second is compression on the optic nerve. So you know that in thyroid, there's swelling of the muscles as well as the fat, and apex of the orbit, where the space is less, where the nerve goes to the brain, the nerve is more likely to get compressed by all these swollen tissues, and that compression obviously leads to reduction in vision, which you don't want. And hence you also use decompression in compressive optic neuropathy. There is a small subset of patients who tend to have this unilateral disease, which is producing an asymmetry. And for such cosmetic concerns also, you can produce, you can go ahead with an orbital decompression. And the last part is what is known as a congestive orbitopathy, which means that at the apex of the orbit, because there's so much congestion due to thyroid, blood is coming in through the arteries. but the blood cannot go out through the veins because the veins are getting collapsed due to the pressure that's built up. So fluid is coming in, fluid is not going out. It's producing a tight compartment syndrome into the orbit, which is known as congestive orbitopathy, which can also be treated with orbital decompression. So I'll just take you through certain cases. This is a 39-year-old gentleman who has proptosis. You can see bilateral, severe. He's in the inactive phase of the thyroid eye disease, which tells you that he's stable now. He's gone through all the fluctuations of thyroid eye disease. Once he reaches stability, you can obviously go ahead and decompress him and give him the cosmetic rehabilitation that he wants. So he has a hurtles of 29-30. Normal hurtles in our subset of patients is around 20-21. So you need to reduce by about almost 10 millimeters, and hence this is a case where you'll have to do all the four walls of the patients. So you can see over here, ideal position of the eyeballs should be such that the line which is joining the two zygomas should actually be going through the center of the eyeball. But you can see the whole eyeball is outside. So that's the amount of proptosis that he has, which needs to be addressed. And he underwent a four-wall decompression. So I prefer to do subsequent surgeries. I operated the right eye first and then the left eye. And this is him after all the four walls have been addressed without any diplopia and an excellent cosmetic outcome. There are certain considerations that you need to have when you're performing orbital decompression. Like everybody, doesn't have the same size or length of fingers or toes. Similarly, everybody's orbit is not the same size. So if a patient has a shallow orbit, which you can see over here, obviously you will have to sort of do more surgery to put that eyeball back inside. So these are considerations that you need to have when you're considering orbital decompression for patients with thyroid eye disease. Again, if it's a unilateral disease, it makes things difficult. And if it is the myogenic variant of thyroid eye disease where the muscles are nice and swollen up and fat, and my slides have gone off. Right. So if the muscle is thickened, then you need to sort of do more amount of decompression to ensure that the eyeball goes back inside, because these are thick muscles. So obviously they're going to need more space inside the orbit. Just leave it as it is. No, just leave it as it is. Can you not do that? Yeah. Just hold it there. Yeah, okay. So when you have this kind of unilateral, this is another patient who has unilateral extreme proptosis. You can see that the left eye is nearly out of the eye socket, and he also has sort of muscle thickening. So these are the cases where you would have to ensure that all the walls are addressed. But then remember, it's only one eye which you're treating, the other eye you're not treating. So whenever you're removing these walls in the orbit, you'll need to ensure that the globe is actually going to be in the center. So you might need to do an unbalanced decompression where you're also removing the floor, and hence the eyeball is likely to move in its horizontal and vertical axis, and hence this patient is always more likely to develop diplopia. You need to counsel them about it. Another case where you have unilateral extreme proptosis, and look at the bulk of the muscles. So these are cases where you will have to put in all strategies that you have in place, like going for the absolute deep lateral wall, removing all of this so that the middle cranial fossa is the only bone that is left. The orbit has to have that much space for expansion, drilling into the lacrimal bone and creating a keyhole there, and also drilling along the basin of the inferior orbital fissure. Any space from where you can sort of expand the orbit is what you'd need to perform in such cases. Certain other patients who have cosmetically disfiguring proptosis, like this gentleman who is very bothered with this inferior scleral show. He is not so bothered with the proptosis which he has, but the inferior scleral show is disturbing him. You might need to consider adding a lower eyelid retractor release so that the inferior eyelid also comes up into position. Certain patients like this who have thyroid eye disease with hooding, you can at times consider customizing the surgery such that you're not only reducing the proptosis, but you're also forming the eyelid fold. So you can see over here that we've done a fold formation on both the sides. This is just 1 week post-operative. You can still see the sutures over there. So for this minimal amount of proptosis, all we've removed is the intracornal fat from this patient. I spoke to you about certain other indications. So this is a dysthyroid optic neuropathy case where even after steroids there was no reduction in the inflammation and the vision continued to be suboptimal. So in such patients, again, you can consider an early orbital decompression to relieve the pressure on the optic nerve and give the patient a fighting chance to have good vision post-operatively. So in dysthyroid optic neuropathy patients, the walls that you typically want to remove are the medial wall and the floor, because these are the muscles which are closest to the optic nerve and can produce compression on the optic nerve. So once you've removed these, the nerve is free of any sort of pressure. I spoke to you briefly about congestive orbitopathy. This is a gentleman with congestive orbitopathy who's undergone an orbital decompression. So to summarize, I've discussed with you what are the walls that are available for decompression, which are the walls that you should target, why you should prefer a balanced over an unbalanced orbital decompression, and the difficulties you'll have when you have a shallow orbit, unilateral disease, and myogenic disease, because all of these sort of give you suboptimal outcomes. We also briefly discussed the role of decompression in dysthyroid optic neuropathy and congestive orbitopathy. With this, I'll go on to the next presentation. Okay, so right. So there's quite a bit happening in the field of orbit, and I'll briefly speak to you about what are these things or what are these advances that we are seeing these days. So again, the topics along which I want to speak to you are listed on the right hand side, and I'll briefly go through these 10 points. Now remember, everything as far as science is concerned is about a perspective. So what I see as 5, you might see as 7. So this is my prism of looking at things which I am projecting to you today. And this is the way I like to think about orbit. So it's not absolutely sacrosanct, but I'll just show you certain things that I do in my practice which give me good results. So like we all know, the role of the orbit is to protect. It has several facial buttress systems. What are these buttress systems? These are actually areas which reduce the weight of the skeleton, so the sinuses and all of that. So they protect. The whole purpose of the entire facial skeleton is primarily to protect the eyeballs, and the second function is to give you a structure along which you can have your soft tissue which give you the facial expressions. So what are the kind of fractures we see in the orbit? You can see several complex fractures like this, where the zygoma and the maxilla are involved. Shahid showed us certain excellent cases which he's managed. You might see a fracture along the medial part of the orbit, which is known as the nasoethmoid fractures. So that's the medial wall and a part of the floor getting affected. These are fractures which are along the skull base, and these are quite difficult to treat. You can have a significant proportion having CSF leaks, and you might need to team up with a whole lot of surgeons to give the best outcome to your patients. What you commonly see is this, which is known as your orbital floor fracture, which can actually be a blowout fracture where the bone is going out, or a blow-in fracture where the bone is actually going in. And what this fracture does is exactly what you surgically create in decompression is what the fracture does. It expands the volume of the orbit, and hence the eye goes inside, and you tend to have diplopia. You can also have so this is just an example of a blow-in fracture where you can see that the bone has actually gone in, and this patient had proptosis despite having an orbital fracture. So that is also rarely possible. Certain interesting things are the white-eyed blowout fracture. Why are they called white-eyed? There's no sign on clinical examination that there is a fracture, but these are ominous. Look at where the muscle is. The muscle is actually in the sinus. This is the normal muscle. So what has happened is the floor fractured, the muscle went into the sinus. Before the muscle could come back up, the fragment of the bone snapped back into position, and that trapped the inferior rectus into the sinus. Now, why is this ominous? This is ominous because this can produce what is known as oculocardiac reflex. So the parents typically will bring you with complaints that, my child is fainting at times, he's complaining of dizziness, he's having headache, we cannot understand, he had a fall, what is going on? And when you image, you'll actually see that, the inferior rectus is entrapped. If you do an ECG, you'll be able to pick up bradycardia and the effects of oculocardiac reflex in such patients. And these are the only patients where surgery is an emergency. You cannot delay the surgery. So you have to put the patient on pressors, admit, and do the surgery as soon as possible in order to avoid the side effects of oculocardiac reflex. And several of us who practice in institutes tend to see these kind of complex pan-facial fractures where you'd have to have an entire team that can help you with the corrections. So when you have an orbital fracture, you need to consider immediate correction for anything that is like a white-eyed blowout fracture. You can see over here a child who cannot elevate the right eye, but otherwise the eye is absolutely fine. He cannot even depress the right eye completely. This is because the inferior rectus is trapped in the sinus. So other than this limitation of elevation, you'll clinically see no other sign of fracture. You'll need to image these, and then these are the patients that you consider for immediate surgery. The others can obviously be planned once the edema sort of tends to go down and you have the implants that you want to use readily available with you. So this is the part which I really wanted to show you. There are several hidden incisions in the orbit that you can use. So you saw those patients with decompressions, the post-op images did not have any scars. How did we manage that? So we managed that because in the upper eyelid, we use an incision through the eyelid crease. This incision gets hidden in this fold which is there, and hence it will not be visible until and unless the patient closes his eyes, and even that incision over a period of time completely fades out. Similarly, to access any part of the inferior orbit, we use a transconjunctival incision which goes from the conjunctiva right into the orbit, and to access the medial wall we actually use what is known as a transcaruncular incision. So it's an incision on the conjunctiva, sorry about that, which actually takes you right towards the apex of the orbit. So these are the three hidden incisions along with which we can go ahead and perform whatever sort of orbital surgery, whether decompression or reconstruction of the orbit that we want to perform. Another small thing that's innovative is using image guidance. So what is image guidance? Just like how your phone has a GPS, it tells you where you are. This equipment tells you where exactly you are in the orbit while you're operating. So it will give you the three-dimensional sort of location of where exactly you are while you're operating the patient. So okay, so I'm just going, don't touch it, I've held it. We're short of time. Oh. ये lose है. Yeah, okay, just leave it at that. Yeah, so this is a patient for whom she has a left orbital fracture, and you can see the enophthalmos that is present over here, and we've used image guidance for her fracture repair. So that's the floor fracture on the left side, and the machine gives you several options of actually planning the surgery. So we are performing a force duction test here, and you can see restriction of upwards movements, which means the inferior rectus is trapped somewhere. The machine shows you the reverse, so you're seeing the fracture on the right hand side right now, but trust me, it's the left orbital fracture. So we are just trying to outline the fracture on the machine and see what is the extent so that we can reconstruct the orbit appropriately. You can do several things, like you can mirror the normal orbit on the other side so that you understand where exactly to place your plate for treatment of these fractures, and that will give you the most accurate sort of outcome. Okay, I sort of missed those steps. I'm hoping it'll play. So this is the actual surgery where we are taking the transconjunctival incision. After the incision has been taken, the floor is exposed. This is the navigation probe. So we are using the probe to understand where exactly the fracture is, and then we are configuring the titanium plate and placing it inside, and eventually again checking with the help of the navigation probe if the plate is where we want it to be, and finally then sort of securing the plate with the screws. So this image will show you what exactly we did. This is the plate going in, and this is the navigation probe. So the navigation probe is actually telling me that this is the location where the plate is sitting, which is good. You see those red marks there. So the floor is fractured. The actual floor right now in the fractured state is here, but with the use of navigation, we've been able to bring the floor back into the normal position where we want it. So that's the use of navigation. The only last part I want to show in this is 3D printing, where we actually print life-size models of the patient's skull, whether it's a normal skull or a fractured skull. You can do this if you have the technology skills with the help of few sort of readily available softwares which are free to download, and you can play around with the CT scan to create the 3D model, to print the 3D model if you have the facility to avail a 3D print. These are actually commercially also available, and they only charge about 5,000 to 6,000 to print a model of the skull. So here you're seeing the orbit of the left side. We've sent the command to the printer, and this is actually how the printer works. It lays down that entire file layer by layer, the exact opposite of what LASIK does, where it removes layers of the cornea layer by layer. Here the bone is being laid down. You can see that this is the contour of the orbit, and this is the support material which is holding the orbit. You then put this in a water bath, the support material dissolves, and it leaves you with just the orbit, and then you can play around and craft all sorts of implants. You can also readily do this by companies which help you in creating patient-specific implants. So you're seeing over here a patient post mucormycosis has loss of the floor and the lateral wall. The rim is not present on the left side, and we want to give him a patient-specific implant to build that area up. So that's the crafting of the implant. So these are companies that make these implants. They print it in titanium, and titanium is very biocompatible, and send you directly the implant which you can use into the patient. Because this is already a specific implant for that patient, you will not need to do any intraoperative maneuvering. You just need to have the knowledge to expose that part of the bone, place this on top, and just screw it in position, making your surgery much, much faster than what you'd otherwise have. One more patient with neurofibromatosis, and in neurofibromatosis you tend to have expansion of the anterior bone but a defect in the posterior lateral wall. So this is a patient where we've crafted double implants, one in the posterior lateral wall because you want to push the brain away from the orbit. Most of these patients due to this defect have the brain coming into the orbit, which is actually producing the proptosis. And we've also crafted one more implant to actually symmetrize the orbital aperture. You can see over here that the right orbit, okay, I'm sorry for that, is larger. So that's the second implant that I was talking about, where the orbital aperture has been symmetrized to match the other side as well. So these are the two implants, and then once you have this, your job as surgeon becomes much easier. The last part that I want to show is this another complex case that has a large frontal defect. The frontal bone is absent along with the roof of the orbit, which is also absent. And again, these are excellent cases to opt for what is known as a patient-specific implant, where you can sort of do all your virtual modeling on a computer and have a very specific implant crafted, which will help you cover the defect in the skull as well as in the roof of the orbit. And your job as a surgeon then becomes much easier. So I think we are at time, and I'm going to end with that. So I've spoken to you about the several nuances in the management of orbital reconstruction, the hidden incisions, the image guidance or the navigation guidance, and the 3D printed implants which are available to any orbital surgeon. Thank you so much.
What was the material of the Medicaid implant?
Titanium. You can ask for, there are two materials available. One is titanium and one is PEEK, polyethyl something. PEEK is supposedly more biocompatible but is also more expensive. So when you outsource this to a company, you would typically be charged something like 50 to 70,000 for an implant. But if you have the skills to do it in-house, and if you have a printer, so it's the cost of the printer, or you could even sort of do the virtual planning yourself and then outsource the printing to several agencies that have 3D printers, just like how you get photocopies done. So then the cost tends to become much lower. Thank you so much. Okay, so we hand over to the next session. Thank you so much.